Welcome to the Destigmatizing Mental Health and Substance Use panel. My name is Kim Lucas, and I'm Associate Director of Civic Research at the Dukakis Center. So thanks for sticking around. Thanks for sticking with us. We've got a really solid focus on substance use, mental health, trauma, all of the above. And I just want to start out before I introduce the panel and we dive into our amazing speakers today, really grounding ourselves. So in the 2010s, if you might all remember that point in time, a person named Sheryl Sandberg coined the term to lean in. Which is the idea that women should seize opportunities, take risks, and challenge assumptions imposed on them. Decades before Sheryl Sandberg even coined this term, Kitty Dukakis was showing us what leaning in really looked like in practice, to seize the opportunity of a national platform and to risk her own vulnerability through sharing her personal struggle in order to destigmatize substance use and destigmatize mental health treatment. Since Kitty began sharing her own story publicly, we have made major strides in both how we understand behavioral and mental health challenges and also how we support individuals, families, and communities who are directly impacted by these challenges. I'll just point out, right, that even how we talk about these challenges has changed so much in the last 40 years. We've shifted from old frames of, and I'm putting this in quotes, addiction, and frames of, again, in quotes, abuse, and these are not the language we use anymore. We're understanding how trauma can affect a life path, and we're also understanding the importance of receiving meaningful behavioral and mental health support. So May is Mental Health Awareness Month, in case you didn't know, which makes this panel incredibly timely. We're going to explore Kitty's legacy and where we are now. What does it look like to support children, youth, adults, families, communities experiencing trauma and behavioral and mental health challenges today? So thanks for sticking with us, joining in, for those of you who are just joining. Now I'm going to hand it over. We're going to kick off with some research, and this research is definitely affiliated with some of the work that the Dukakis Center has been doing. We're going to start with Dr. Beth Molnar, Professor of Public Health and Health Sciences and Faculty Scholar at the Institute for Health Equity and Social Justice Research. So Beth is going to be here, and she'll ground us in some of the research work, and we'll let the panel take it from there.
All right, good afternoon. Thanks for having me. As a town meeting member in Milton, Massachusetts, the pariah of the MBTA Communities Act and processes, we got it done, yes. And so I really appreciated that previous panel and learning more from your side about what we were doing there and the tactics and et cetera. So today, I want to share results with you from a body of work that I believe demonstrates that embedding mental health support at the point of infancy directly into the places where families already go, for example, their children's pediatricians, can make a profound difference for both young children and caregivers. So what is early childhood mental health, and what does healthy development look like? So I want to start with describing that and why it matters to take care of mental health for children and for caregivers from infancy forward. This provides protection and resilience when trauma and other adversities happen to families and communities, and this resilience can help prevent conditions such as the precarious housing and substance use disorders and other things that we're talking about today on this panel. This figure has as its center healthy social and emotional development. It's the goal we're working towards when you're working with young children or parenting. Four critical capacities that feed directly into it are shown by arrows pointing inward. So first, children need to be able to explore their environments and learn, to be curious, to play, to take risks, and discover who they are and how the world works. Next, they need to form be able to form close, secure interpersonal relationships, first with caregivers and other family members, then with peers and teachers. Those early bonds are the scaffolding for everything that follows. Next, they need to learn how to experience, regulate, and express their emotions, not to suppress feelings, but to recognize them, manage them, and communicate them in ways that allow them to thrive in families, in classrooms, and in their neighborhoods. And lastly, they need to develop self-regulation, and this leads to resilience, the capacity to adapt when things don't go as expected, to persist through challenges, and to recover from adversity. So none of this happens in isolation. The outer circle reminds us that every child's development unfolds within contexts shaped by family, community, and cultural expectations, as listed at the top. What looks like healthy emotional expression in one community may look very different in another. Similarly, child development happens in a context of whatever else is happening to the families and to the communities, which may include lots of different adversities. Effective interventions must be responsive to these contextual differences. So this is the framework that guides our work to promote early childhood mental health. We know that struggles in any of these areas can be detected as early as infancy, and there are evidence-based interventions that can help children and families get back on track. So since 2012, I've been working with the Boston Public Health Commission and the Massachusetts Department of Public Health to evaluate their efforts to improve mental health and build resilience among children 0 to 8 and their caregivers. We began by evaluating a model we call Massachusetts Project Launch. Launch is a program funded across the country by SAMHSA, a federal agency. Launch stands for Linking Actions with Unmet Needs in Children's Health. The core innovation of Launch in Massachusetts is pairing two types of professionals, a master's level early childhood mental health clinician and a family partner, a paraprofessional with lived experience raising a child who would face social, emotional, or behavioral challenges. Together, these teams worked from within pediatric practices at community health centers, inside the medical homes for families who had experienced trauma and other adversities. The model is also holistic in its service delivery, using a lot of case management strategies. It's family-centered and focuses on both health promotion and prevention. So the original study followed 225 children, ages 0 to 8, and their caregivers across 3 community health centers serving predominantly low-income families of color in Boston. We assessed participants at baseline, at 6 months, and at 12 months using validated screening tools for children's social, emotional, and behavioral health, as well as for caregiver stress and depression. So what did we find? For the youngest children, ages 1 through 5, those who began the study with social, emotional, or behavioral screening scores in a clinically concerning range, had on average moved into the healthy range by the 12-month mark. The improvement was statistically significant, with the greatest gains among children ages 4 and 5. For older children, ages 6 through 8, we also saw success that those who started with elevated problem scores on a different measure saw a reduction of over 25 points, or a 37% decline by the study's end. And children who began in the healthy range stayed there. The results for caregivers were equally compelling. Parents and guardians who entered the study with clinically significant parenting stress saw their scores drop by an average of more than 17 points, moving from the high-risk range into the healthy range by 12 months. And caregivers with clinically elevated depressive symptoms had a similar decline. And again, caregivers who began in healthy ranges maintained that status. So what's striking about these findings is that they reflect improvements not just in children, but in the adults around them, suggesting that Massachusetts Project Launch was addressing the family system, not just the child in isolation. Of course, we always need to be clear-eyed about limitations in a study. This was a longitudinal evaluation without a meaningful comparison group. Budgetary constraints prevented full comparison site data collection. The screening tools were used to monitor change, not diagnoses. And some families were, of course, lost to follow-up. But that said, our sensitivity analyses confirmed the results that even when they only completed 2 or 3 assessment points, we still saw the same results. And so the implications have been significant. It brought Project Launch in Massachusetts into the echelon of evidence-based practices. It won an award from the Association of Maternal and Child Health Program, AMCHIP, for the best practice submitted to their database in 2021. So the results supported sustainability efforts and the development of an online toolkit, ecmhmatters.com, for other communities interested in implementing similar programs. This is the kind of scalable, community-grounded model that has the potential to reduce disparities in access to behavioral health care for young children, disparities that, left unaddressed, as we've talked about many times today, can follow children for decades. Next, the ECMH team was funded to do an expansion of the model to additional communities across Massachusetts, then to try it with children in the foster care system in collaboration with the Department of Children and Families. And the most recent funding is allowing us to expand into existing home visiting programs delivered to families with similar vulnerabilities. And here at Northeastern, along with our public health department partners, seated by the Community-to-Community Impact Lab, as well as the Center for Design at CAMD, we're working on obtaining larger funding to develop technology that we believe will better support the family partners in their work, their exposure to vicarious trauma, for example, their professional development, as well as improve service delivery and communication with the families they serve. So I want to finish this brief talk with some of the qualitative data we collected along the way to share more about the vital role played by the family partners. So here we have the caregiver perspective who said, I was stressed, like really stressed out until the family partner came and everything just calmed down a lot. And from the clinician's point of view, I feel that when the family partner shares pieces of her story, parents really connect and they don't feel alone and they feel understood by their providers. So early childhood is a critical window. The evidence from this body of work suggests that when we meet families where they are, such as in the pediatrics office, with culturally grounded partners who understand their lives, we can help put children on a healthier developmental path. Thank you.
Thanks, Beth, for kind of grounding us in this understanding that there's so much more than just an individual that we're focused on. We're looking at a whole ecosystem of a family. We're looking at a whole ecosystem of clinicians. We're looking at a whole ecosystem of support. I want to introduce all of you to Jade Bolger, who is Director of Clinical Services at Bridge Over Troubled Waters. Jade has had more than a decade of experience in this space and is a leader focused on youth homelessness and really thinking about practical models that actually reach folks and provide access to folks who really need it. So I'll turn it over to Jade with a starting question that might help introduce you and your work to everybody. Bridge Over Troubled Waters was founded in the late 1960s, if people didn't know that, by a group of women serving youth who had no place to go. Can you talk a little bit about what Bridge Over Troubled Waters does today? What about the youth service model has stayed the same? What has changed in the last 50 plus years?
Sure, thank you. Thank you all for having me here today to speak about mental health and substance abuse and youth homelessness. So yes, in the 1960s, a group of nuns from the Order of the Sisters of St. Joseph noticed young people were in the Common, Boston Common, and in Cambridge, and they were separated from family and separated from resource. So they started bringing out food to them and started to have casual conversations that led into counseling, and then they eventually founded Bridge Over Troubled Waters. So that initial street outreach model we still have today. And they also started a mobile medical van with a group of physicians from Mass General Hospital, which became a national model and is also still used today. But we've grown a lot from those two programs to now we have a day program where young people can come in and get access to shower, food, laundry, case management, groups, activities, places to store their belongings. We have behavioral health therapy, access to psychiatric care on site. We have access to medical care on site. We have a high-set prep class, and in the last few years, we actually added a high-set testing site so that the young people don't have to travel elsewhere to take those high-set exams. We have career development, and then we have a continuum of shelter and residential services to serve people on a night-to-night basis, and then through transitional living programs, and most recently, our graduate living programs, where young adults can have a place to live for up to 2 years independently, where they're only paying $275 a month in rent. And with that comes along with a financial literacy course so that we've been exposing our young people to savings and investments and budgeting. And then our most recent, not necessarily program, but thing that we're really proud of is that in the last 6 or so years, we have started to develop a formalized research center, which is named after one of our founders.
Awesome. Thanks, Jade. I'm going to also introduce and bring into the conversation Brendan Little. Brendan is a co-director and co-founder of HALO Initiatives, and HALO is an acronym that stands for Healing After Loss to Overdose. He's also formerly the policy director at the Mayor's Office of Recovery Services here at the City of Boston, and a dear friend. And so, I'll kick off again with a little intro question for you, Brendan. Can you just talk a little bit about where the idea of HALO Initiatives comes from and maybe what gap HALO is filling?
Sure. Hi, everybody. I'm Brendan Little. I'm the executive director, co-founder of HALO. We always joke, we as my co-founder, Elsa Gomes-Bondlow in the audience, and we joke that it found us. We didn't find it. I was at the City of Boston at the time working in substance use field, and I would field constituent calls about things that they were dealing with related to substance use or quality of life concerns. And one of the things I started to get a lot of was family members that needed support burying a loved one after overdose. And there was no resources. I was calling around to other city departments to try to find something, and there was nothing. I'm in recovery myself. I have lived experience with substance use and homelessness, system involvement. I was in DYS, DCF as a young person, so it's something that I really understand. My mother died by suicide, overdose as well. So this is all stuff that was really near and dear to my heart. And we were a little confounded because there's all this opioid money that's starting to flow to communities. And what I mean by opioid money is when there are these large lawsuits against opioid manufacturers and distributors that is now flowing into all these cities and states across the country. Massachusetts being on the forefront of that because of the governor during her time as AG was really active in that space. That's all to say, now we have opioid dollars flowing into the community. And so I would get those constituent calls, and I didn't have anybody to reach out to. So I reached out to my colleague Elsa, who's here again, because she had philanthropic ties, and we would just start paying for these funerals by ourselves. No infrastructure, no support. And we did that for 5 years, and we served 16 families during that time. But we also wrote an op-ed in the Boston Globe to say opioid dollars should be spent on this because it's an intervention point, it's a way to interrupt cycles of intergenerational trauma, and it's a way to support a family in their time of need. So the city of Boston kind of got hip to that. They put out a RFP, and then we applied, and we've been running it for a year now. We served 50 families last year, $220,000 for funerals, behavioral health supports, child wellness, legal fees. And we just recently got a RISE Massachusetts grant to expand to other parts of the state. So that's kind of the story of how it chose us.
Oh, fantastic. Thanks, Brendan. And last but certainly not least, Dr. Nathaniel Van Kirk, who's the program director at the OCD Institute at McLean Hospital, and also president of OCD Massachusetts. Nathaniel, what I'd like to do to introduce some of your work is what I noticed in our prep call very recently, is that your work straddles the line between research, practice, and lived experience. And that's a lot of the work that we do at the Dukakis Center and at Northeastern. Can you talk about some of the challenges that you see in being able to bring research and evidence into the treatment space?
Definitely, and thank you so much for having me and for walking me through kind of the prep call this morning. So what initially brought me as to part of this is the Deconstructing Stigma campaign with McLean. So years ago, actually, the day I finished my postdoctoral fellowship and no one could take away my degree as a psychologist, I was actually part of the Deconstructing Stigma campaign where I shared my own experiences with OCD and talked a lot about stigma within the medical field itself. I did a grand rounds on that last day with the blessing of my supervisor, and I was like, well, can't get fired yet because I'm done at 5 o'clock, so, let's see what happens. And it turned out to open up a whole kind of can of worms in a sense of this idea that having lived experience, being a clinician, and being a researcher were really seen as these very separate worlds that never interacted for many, many years. And as a clinical psychologist going through my doctoral training, it was always one of those things that you were sort of told, like, don't say anything about it. But then there was also no mentorship, like what do you do about it? And I think this gets to that question of like, how do we bridge the gap between all three of these? But really one of the big challenges is how do we get the voices of those that kind of live and work in all of these areas and bring them together in a way that can get out to the community as well and be able to really disseminate empirically based treatments and care, especially for really high severity symptoms and those who are really struggling and feel like they have nowhere left to turn. And that's sort of what we do at the OCD Institute. We're a residential partial hospital program that is insurance-based. We accept Medicare, Medicaid, and we're one of 2 in the country, which really gets to one of the challenges of disseminating intensive, empirically based care that is based on current research in sort of a clinical fashion is very hard to do. If it weren't for like the backing of the large hospital system, a lot of these intensive treatment programs are very hard to make feasible in the long term, and we've seen many close in the last 10 years, unfortunately. And so I think there's a couple main challenges that come up that I'll say very quickly. One is we know funding, especially when it comes to behavioral health and mental health research, is very hard to come by. The other is that we do know there's about a 7-year delay in dissemination between empirical research coming out on best practices, especially in areas that are not as well researched. Like OCD used to be this for a long time. It was considered something that was unique or different. No one really knew what it was. And so no one really talked about it or even trained people on it during graduate training. And so there's about a 7-year delay, and that's something we really need to speed up. But I think one of the other things that really comes from this is there's been a great push in dissemination, which has really raised awareness about the fact that there are great treatments for substance use, for depression, for PTSD, for trauma-related disorders, for OCD, for anxiety disorders. But the challenge is also how do we push out and make sure what we're pushing out is empirically based, because there's also a lot of misinformation that comes out. And so in my role, I see many clients who have come to our residential program as a last stop after 15, 20, 30 years of getting the wrong treatment or have been misdiagnosed, thinking they're untreatable, and then coming to us and realizing, no, they've just been getting the wrong treatment. And I similarly, when I went through my own experiences, that's sort of how I got into the field, as I realized for the first about 5 years of my treatment, I was actually getting the wrong treatment, and I was labeled as untreatable. Then come to find out, well, no, not untreatable, just what you're telling me to do didn't work and had no research behind it. So that's what drove me sort of into this field, is how do we bridge that gap a little bit and make sure, and I loved what you all were saying of doing these empirically based kind of implementations and gathering research and data on them, because I think that's one of the biggest ways that we can close that gap is by making sure everyone's participating in all parts of the process and talking. So short and sweet.
Awesome.
Hopefully answered the question.
No, thank you. And thanks to all our panelists for being here. We're going to get into the meat of it. And so what we're going to do now is just have a conversation. I'm going to invite all of you to think about questions that you want to ask the panel. So we'll have some open time for Q&A. And do we also have a Slido? Okay, all right. It's all the same code, my friends. And so we'll gather your questions. But I'm going to kick off with a question of my own that I just noticed in speaking with all of you as we were preparing for this chat. You know, I mentioned in my intro that one of Kitty Dukakis's legacies is her pioneering leadership in destigmatizing and humanizing behavioral and mental health treatment. And one thing that stood out to me when we were all chatting is, and the work that you're all doing, is that your focus is really aimed at getting folks to a place of resilience, right? And I think, Nathaniel, you put it really well in that, like, how do we get folks from being labeled as untreatable, you know, unknowable, we can't do anything for you, shifting all the way to, actually, you're a resilient person. You're a resilient being, and these are the things that we together, we can do with you. And so, you know, can you all talk a little bit about what this means or what this looks like? And you all work in, I would say, like similar, but also very different spaces and places with different populations. And so what does that mean or look like in your work? What does resilience look like? And why is building resilience a central focus rather than, say, something more prescriptive? Like, you know, we talked a little bit in our prep call about scared straight tactics that we used to do, right? And so we've made a big shift. What does that mean for you these days?
So I can talk briefly. Just kind of the idea of resilience in the work that I do, primarily working with OCD and anxiety and fear-related disorders. Exposure-based treatments are sort of like the main empirically based. We have years and years of evidence that they work really well. And so when people come in, one of the things we talk about is that our goal in treatment isn't necessarily just to get rid of this one fear, but actually to learn to sort of live with fear and uncertainty, because that's what it means to be human as a whole. I always kind of joke that our job is to help people face fear effectively and efficiently, because if you can face the worst things that your mind can create, there's very few things in life outside of there that you can't overcome or go through. And so when we talk about our approach to treatment, even at very high levels of care, so at inpatient, at residential, we are really talking about how do we help someone find their own resilience and kind of remind and learn for themselves that I'm actually way more capable than I'm giving myself credit for, or that others may be giving me credit for, to face whatever life throws at me and find my way through it. And I think that is sort of the hallmark of like OCD treatment, of exposure-based treatments. And it's also something that as humans, we all do naturally. And the last thing that I'll say about that is when it comes to destigmatizing it, I always like to point out that we talk about these behavioral health experiences as something unique that we have to figure out what to do about. Statistically speaking, across a lifespan, 1 in 3 people will meet diagnostic criteria for some sort of behavioral health condition or a set of symptoms that are causing impairment in their life. 1 in 2 will be significantly affected by it, be it through a loved one, a significant other, or a child. So navigating behavioral health and mental health is the norm. It's part of being human. It's not necessarily the exception to the rule. And so I think that's a really important thing that we can continue to push forward when we talk about resilience. That is what we do as humans. We're resilient. We find our way through.
I think one of the things I think is not all stigma is created equally. And when I first started in the substance use field about 10, 12 years ago, it was all these anti-stigma campaigns. These are people who use drugs. They're people, and which I think was very much needed and important. But it didn't trickle down to every demographic. And because the more kind of social determinants of health, or the more barriers you have, the more identity, attributes that you have, be it black, brown, queer, poor, having a disability, those people aren't able to walk out like me as a white man and say, I'm in recovery, and everybody claps and they're happy. Like, those people, when they say that, it's another level of burden and another level of disparity and discrimination and bias. So what we've really been focused on is, like, while we were doing this, paying for these funerals just by ourselves, we realized we were meeting an unmet need. We would bring it up. We had positions of power. We knew how to talk to people in power, and they said, that problem doesn't exist. It's not in the data. I don't see it because you haven't reached them. So we were just reaching them because they reached out to us. And now it's a thing. Now we have data because it is there. It's a documented problem. So I feel like part of it is, it's like, knowing that you mentioned something in your question about like different treatments or treatment modalities. Like, if you don't know that there's a problem there, or you can't admit that there's a problem there, you can't treat it. So with the people we served the city of Boston for the last year. We serve primarily black and brown residents in the city of Boston. And that's something we're very proud of, because a lot of recovery supports are disproportionately white. So we're very proud of that, and I feel like we're able to cut through a lot of those disparities to get to the core of the matter, and then use finances, use money as a means to help them improve their life at a really difficult time.
Yeah, and stigma, of course, affects families with very young children in a lot of ways. They don't want a label on their children, and a diagnosis, is seen that way. And the individual education plan, IEPs, and all the other services can feel stigmatizing. And so I think the intervention I described is helpful in getting families through that, understanding all the benefits of that. But one thing I wanted to mention from our current study evaluating this program in the foster care system is that the parents are filling out these social, emotional, behavioral difficulty questionnaires in the context of the services that they're receiving, and the kids are scoring very healthfully on all of them. And so that's a puzzle we're trying to figure out, because if you're in the evaluation world, if you start out with people who are really healthy, you can't show any change when you follow them up because they're already there. And so we're trying to figure that out. Is it the stigma of these foster care parents or families wanting to look better? You know, are they not wanting their charges, the children in their care, to get these labels or to have, evidence of these symptoms? So we're trying to figure that out as a puzzle, because clearly these babies and toddlers have been through immense tragedies and trauma, and yet they're scoring super healthy. So that's a piece of the puzzle we're trying to figure out. Like, stigma's clearly playing a role in how can we, get inside there and figure it out.
Thank you. And I'll piggyback off what Nathaniel said of how humans are resilient. At Bridge, we're working with young people, so 14 to 24 years old. And so while they're coming to us with the needs that they show up with at that door, we know that down the line, having challenge and having stress in your life is also human. So we're hoping that we can help them build up their skills and their toolbox to see that they're resilient and that they can pull on that resiliency later in life as well.
Awesome. I'm going to say the questions are rolling in, at least on the Slido. So in the room, and I see Chris Basso and a couple other folks in the room have questions. I'm going to start with a question from the Slido, and then we'll toss it over to Chris, who's holding the mic. And so on the Slido, we've got one person who says, I can imagine one family needing multiple or even all of your services. How do you all collaborate and refer or support families among different organizations and agencies?
Well, we've actually collaborated, Jade and I, on I was working on some stuff around Mass and Cass. If you're not familiar, it's the area where there's a lot of concentrated substance use services, as well as illicit substance use and dealing. And we were noticing a lot more young people down there, and I was just seeing a lot more young adults. And I raised it to the state, and we talked with Bridge, and Bridge came down, and we did a whole assessment in collaboration with the state to just get these young people triaged and get them to some different spots. I feel like, and that was an education point for us too, because I feel like there's so many young people that kind of fall off this cliff at 24, because all their services kind of run out and they're not quite ready yet. So, but that's just one example, and then we know a mutual person. We're connected, but I feel like there's, Elsa always says we're resource rich, connection poor, and I think that that's really true in Boston. So it's always good to have events like this so we can connect.
And I always tell my team, I say, your colleagues may be in this building with you, but your colleagues are also everywhere out in the community. So every time you're making a referral or connection for that one young adult you're working with, keep that in mind, because that's going to be your partner in another area as well. And we have so many services in our building, but we also always say we need so much more support from other agencies out there, that we can't do everything. We can't be everything for everyone. So we're always trying to build up our connections and our partnerships. And we have Boston Healthcare for the Homeless come on site. We have partnerships with Massachusetts General Hospital Center for Excellence for research. And the Department of Mental Health also comes on site as well, so that we make sure that our young people are connected and they can get resources in-house and elsewhere.
And I also think, I like what you said with doing these type of things is sometimes how we do get connected, because Massachusetts probably has more mental health resources than any other place that I've lived in the country and worked, and it is interesting in the sense that we are somewhat siloed, but it is these events that all of a sudden the connections sort of develop. I will say, when I first moved up here and started working at McLean Hospital, I quickly figured that out when I told someone where I worked, the hospital on the hill is what we are known as. And that very quickly, I think, alluded to the idea of inpatient and intensive treatment. We don't really like to talk about, and we don't even call it what it is until everything goes wrong. But a lot of times, we can collaborate across the levels of care, and I think the biggest part that's missing, if we really think about where the services are placed, is the transition between levels of care. And so a lot of it really comes down to what you all were saying, of making that connection and saying, all right, we're going to find a way to do it. But there's no way that the policies and the insurance and the reimbursement, they actually don't allow for a lot of those transitions of care to happen seamlessly. And that's actually one of the biggest challenges that I know we see from our end is reintegration into daily life.
And I'll add that where this comes into play is the case coordination piece that I mentioned. So I said the launch team does a lot of work with the families around case coordination and more of, a social worker role. And where that presents a challenge over the years is figuring out sustainability, because the reimbursement for case coordination is not the same as the reimbursement for the mental health clinician's time, for example. And so figuring out how community health centers and other places that employ the teams that I'm talking about can pay for that case coordinator time spent to hook the families up with lots of different types of services, that's another challenge.
Awesome, thank you. And there's a question out there. Yeah, go for it.
So, playing into the theme of stigma, but also resilience that Kim raised, I'm curious on how you've seen, the social media over the last, say, decade or so, the impacts of social media on not just your clientele and their mental health, but also on how you do your work, or how to impact your work. So, how does it play a role, say, in the last decade or so? What have you noticed? I'm curious about the impacts of social media on mental health kind of questions, like basically.
I'll say briefly, I could talk all day about this, and we've published some papers on it, because when it comes to like OCD and obsessive compulsive disorder, social media has played a huge role. It's been great to raise awareness. It's also been incredibly detrimental in other ways as well, as it became more monetized, and it became less about pushing out good empirically based information and more about excitement and interest. And so only certain parts really get highlighted. And I think one of the things that we also have found a lot that's been happening, this happens now with AI, and I use a lot of AI in kind of day-to-day stuff, but one of the challenges that happens with that kind of validation kind of protocol is that we actually see it making symptoms significantly worse and eroding trust in the providers and the people in the community that are there to help support and have the experience. And that has been a large issue. It also has, researchers are notoriously not very good at social media. I think it's something that we talk about in the training programs a lot, is we don't do a lot of it, and we caveat everything. And unfortunately, that doesn't build a lot of confidence as much as we had an issue in the OCD world where someone was saying celery juice cures OCD. Hate to break it to you, it does not. But it took a year of work to try to disprove that, where people said that we were torturing them by giving empirically based treatment because we could just be giving celery juice. So that's a short caveat. I have a lot of thoughts on that, but it's been very beneficial and very challenging at the same time.
I can say we're trying to harness some of it. Michael Magis is here, one of my partners on the work, to try and get a new tool, technology tool out, developed and helping the family partner with their work. And so some of the things that we're tossing around as ideas for that are games and chat bots and chat rooms for the families who are receiving services to talk with each other and to talk with their family partner in a monitored kind of controlled social media kind of way. So hopefully can use it for good as well.
I've got a question from the Slido talking about the missing middle. So how can those in the missing middle maintain mental resilience when their income is too high for public aid and too low for rising costs?
I actually worked on something like this for the state because they were paying their CAB members, community advisory boards of homeless youth, and it was messing with their benefits. So it's like this is something that comes up a lot in trying to think about different strategies. One of the things that was really important to us about starting Halo was that there's no income requirement because overdose affects everybody, and this money that's coming to us that we give out to families comes from lawsuits where there was malfeasance and there was serious neglect. So we believe that that money rightfully belongs to families who have had a loved one die of overdose. So I think that part of it is really getting a real-time look at what's going on in people's lives. And for that, you often need money that's nimble, which is very hard to come by, especially these days. However, this opioid money is. And I think that's something that's really interesting for us, is that it's fairly abundant across the country. Most people aren't spending it. So we're really trying to think about paths to be creative with it to help shore up other programs like these people who are doing incredible work, where their young person is doing well at Bridge, but they don't have enough for their books for school. Okay, we can help them with that if they had a loved one die of an overdose, right? Or they need tools for their job that they're going to. That's kind of how we envision it, as this way of interrupting people's struggles and various traumas, and with targeted and smart financial moves paired with great behavioral health partners and paired with great peer partners.
Thought we had a couple of audience. Yep, go for it.
Hi, I'm very curious if you have thoughts about gender and maybe looking historically, if you have that knowledge, kind of about the trends. One of the reasons I asked this question is because one of the things I admire about Kitty Dukakis is, being a feminist and also the extra, I think, risk that it took to write her book and be so straightforward as a woman. So I'm just curious about kind of issues that girls and women especially face with mental health and the treatments out there, and kind of what you've seen change and maybe what hasn't. I mean, I care about everybody, but I just wanted to ask that.
I will say on the research side, I think one of the things that we do know as within kind of behavioral health research is that much of the early research really was done on men and then extrapolated. And I think one of the things that I know is coming up a lot in the OC world is postpartum OCD. And we saw this with postpartum psychosis. Really hadn't been researched. It was just sort of like assumed and then sort of put out there without really a lot of validation. And that has been shifting, which has been great, but there's a lot of ground to make up that really just the research wasn't done. And now we're realizing that actually we need to redo some of that research and actually double check and make sure, do the results stand? And what are the things that we are missing and aren't being addressed that we're just making assumptions about? And I think I have a colleague who's Dr. Falkenstein, who's the director of research at the OCDI, who's starting some new work on postpartum OCD, which some of the prevalence rates that are coming out around, we know that having intrusive, distressing thoughts following having a child is actually about 94% of individuals will report them. And it's sort of the idea that the others probably are having them but aren't reporting them because of a fear of what are people going to think about it. And then those that may go on to develop postpartum OCD seems to be much higher than we would see in OCD development in the community. But that research really just started. And so it has a lot of ground to make up.
I would add wearing a different hat from my early childhood mental health hat, which is my sexual violence hat as a researcher. And so I think the disparity in how much women and girls and women-identified people are survivors of sexual assault makes a huge difference in the prevalence, especially of post-traumatic stress disorder in the world. And we're swimming in a world of news and awareness about sexual violence at the moment in our country and around the world. And so I think there we have a lot of work to do still.
We've got a Slido question that's, since not all stigma is the same, what are some innovative or effective ways to deal with stigma that you have proven fruitful?
Well, I guess at Bridge, as I talked about, we have our new research center, and one of the things that we've really been working on is peer recovery. We also have opioid settlement money, and so we've been able to train a lot of our young adults to train them in overdose response methods, and then they're trained as peer recoveries, and they train the other young people there. So they're learning a lot more about harm reduction, and this is helping to destigmatize the conversations that we're having about substance use. We've also developed 2 different treatment models, one that focuses a lot more on people who aren't ready to discuss their substance use or to discuss that their substance use could be a problem, and then another one where people are ready to make changes. And so by offering these 2 different kind of like levels of services, we're making sure that it's equitable and, again, destigmatizing it. And with that peer recovery model and the overdose response, we've actually had several young people in the downtown Boston area respond to overdose and be able to save a life.
I think that one of the ways that you can really get at stigma that's a little bit harder to get at or harder to raise awareness about is through lived experience. And, you know, like I have lived experience with homelessness, with substance use, with poverty, with, you know, family suicide, family overdose. Elsa has, you know, she's an immigrant black woman, you know, like come here, like has to battle her battles. I've had my battles. And I think we both bring that to the work. And I think that when I talk to a family, almost always they're like, he was a good person, right? Like I know he was a good dad. And I'm like, you don't have to tell me that. I'm in recovery. Like, I know this. I've known many good people who have died by overdose. And I'll honestly open with that oftentimes. I'll let them know my own personal experience, not as a way to make it about me, but as a way to say, like, you have permission to talk about this, and because what they're used to when they're applying for money from somebody is having to lie, is having to say, things are better, no, there's no substances, you know, because that will get them in trouble. So we say, nope, we're here to support you. Like there's times where family members have died and they hide all the drug paraphernalia because when the police come, they don't want them to know there's an undocumented family member in the next room, right? So they're fearful of that. So you can't just go out to that person and say, go out and say you're in recovery or that you lost a loved one to overdose and you're the poster child of that now. They're like, I'm just trying to survive, right? So I think that, but we can tease that out with patience and with lived experience and with dedication and care to really pull people out to say like, yes, you know, you can be open about this and this is something that we're seeing because again, before we were doing it, it didn't exist. The problem wasn't there because it wasn't documented. Now it's documented, so we have to solve it. And I feel like the key part, though, is utilizing lived experience, not as a way to just say, oh, yeah, you know, I know what you've been through. I always say, I don't know what you've been through, but I have an idea of what it's like to lose a loved one to overdose, and it's difficult. So I think it's that mix.
If I could piggyback off, I love kind of when we're talking about the aspects of stigma, just as a researcher, I can't help but go into data. But there is some really great research coming out around mental health stigma, and Deconstructing Stigma campaign when it first started was looking at some of this data, and there's an interesting discrepancy that we saw in it. That one is well over half of individuals surveyed said they would be unlikely to share dinner with an individual with a mental health condition. Now, if we look at the data, how many of those individuals that said I wouldn't share dinner with, how many do you think they actually have? And actually do on a regular basis, but just don't know it. And so I think it gets to that idea of like sharing that story and how you share it. And it goes to, there's been some other research about how do you effectively reduce public stigma. And what they found is the most effective way to change beliefs about stigma, especially around mental health, is to have someone overhear or learn about something that they think they weren't supposed to know about by accident. And they're more likely to change the way they believe than if someone was to show them data and say, see, this is wrong. They will double down, because humanity sometimes does that. But if you actually set it up to where they get to know you in a different way, or they find out that, oh, someone I really like, someone I connect with, or someone I thought had it all together has struggled with mental health, they are more likely to change their perceptions about mental health because they feel like they learned something they weren't supposed to know, and it has a greater emotional impact on us. And so I think how we get the message out matters just as much as what message we get out. And we can pull a lot from marketing. And that's actually where this came from, was from a social psychology study on marketing that they applied to stigma, which I think is quite fascinating. The other thing I would say is we talk a lot about public stigma, but it's important to also highlight internalized stigma, which is where an individual takes the messages they hear and essentially assigns them to themselves. Because we actually see that's one of the biggest challenges when it comes to engaging with care, even if it's available, is what will people think, or what does this confirm about me if everyone finds out? And so I think we can also do a lot to help individuals, give them tools to change their own beliefs about mental health and their own internalized stigma and notice when it is getting in the way. Because we're actually seeing that that's probably the more impactful aspect of stigma, because it gets in the way of asking for help.
And I would add that the study I showed you about the family partners and why they're so important, the lived experience that they were hired for helps with stigma a lot. You know, there's stories in that paper about the ways that them telling the client, the patient, how this went for them with their child with special health care needs or special mental health care needs really makes a difference in the openness of that family to services.
Okay, we could do this all day long. So in some places we have. But because we only have about an hour, I'm going to wrap up with my own question. And thank you to everybody in the audience here, live in person, who have questions and shared them. And thank you to all of the folks online who are continuously submitting questions. I'll share them with you guys if you'd like afterwards. But my last question, moderators, kind of purview here, is for all of you on the panel, what is one thing that folks in our audience, either here in person, folks out in the internet live stream world, what is something that folks in our audience can do to support the resilience of folks who have experienced trauma or who encounter behavioral or mental health challenges? Anything you want to ask these folks to do or suggest that it's available to them?
I think the point I made about that these difficulties can be recognized super early is an important thing for all families to know, no matter how much adversity they've experienced or not. I think that there's ways that we can intervene really early, and that's kind of my message today.
Mine would be to lift up people's strengths who have faced barriers or experienced trauma, and to also lift up the power of social connectedness. So be a support for people experiencing trauma, and if it's for yourself, to seek out that support.
I'd build off that with the social support, and also knowing that helping hold hope and being curious about their experiences and not making assumptions about what someone has gone through or how it's impacted them, because that can help people find sort of those good empirically based treatments. And if you have a chance to influence reimbursement policy or talk to policy holders about it, please bring it out and push it, because it is one of the biggest barriers for getting great care out there when we have all these amazing resources that everyone on the panel's talked about.
I think one thing I always try to get out is not all lived experience is created equally as well. I think that's another thing, right? Because if there's somebody who has lived experience and they're trying to limit somebody's rights, or trying to hurt them or put them in a punitive setting or ship them away or whatever it is, don't listen to them. That's my advice. If they're trying to build bridges and connection and solve problems and support people and find commonalities, that's a good person to listen to, because it's hard to tell, right? Sometimes you come in, people say, I have lived experience. Everybody with substance use disorder, you should lock them up. That's what helped me, right? Maybe it did. That's okay. That's not a good policy choice, though. So I think it's important to be mindful and to discern that the lived experience you have at your disposal, who you're listening to in order to support programs, either at a policy level or fundraising. Make sure you're listening to the people that are trying to build coalitions.
I love it. And just to bring us back, right, to where we started, which was thinking about Kitty Dukakis's legacy in this area around destigmatization. You know, one of the things that Kitty herself did was put herself out there. She was very, very brave at a time when, you know, to the point, she was a woman, a powerful woman, very few of them existed in that moment, who said, this is who I am. And in fact, if I can say this, maybe you can say this. It's an invitation for you and for others to join in and become a community around what folks what folks are struggling with and what challenges folks are facing, such that maybe together we can figure out how to get through things together, right? As a community, as a group of folks who, as plenty of resources exist out there, and you are not alone. And so I want to thank the panelists for giving their time, sharing what their experiences and their work. And I also want to just say, if you, like me, so this is not my research area, are new to the conversations around trauma, around substance use, around mental health, please do check out in the lobby. There is the Deconstructing Stigma exhibit from McLean Hospital, and it's out in the lobby. It'll be on campus if you all are in or near campus for the rest of the month. And so invite you to that's a great starting point. So thank you all, thank you panelists, and we'll be off on a coffee break, everyone.